I'm Renzo Quinto from the Philippines. As Uni said a while ago, I just finished medicine, so I'm jobless at the moment. But thanks to the UIO, Institute of Health and Society, that you've given me this opportunity to share about the Philippine experience, the Philippine perspectives on global governance, on social determinants of health, and the subject or the concept of health equity. Thank you to Uni, thank you to Inger, and to all my friends from the Lancet UIO Commission for having me here. Also special thanks to our consul from the Philippine Embassy here in Norway, Consul Lena, and to her husband Marlon for gracing this occasion. And so I'm quite nervous now. I have some people from our foreign service. I hope we will be working together to bring health at the center of foreign policy also in the Philippines. So this will be my outline. Shortly I'll talk about the Philippine health situation, how the social determinants of health are affecting the health of Filipinos, the structure and the current issues faced by our healthcare system, and how health actually is incorporated in the many foreign policy issues that we face in the country. And hopefully we gain some take-home lessons as well as more questions, because that's what we need now more than ever, to really raise the crucial questions so that we can enhance global governance to achieve health for all. And since I mentioned health for all, every time I talk about health equity, global health, I always begin with mentioning the Alma Ata Declaration of 1978, which I think after the creation of the World Health Organization in 1948 is the most important milestone in global health, in the way countries try to address health issues as a global family and not anymore as individual nation states. And as a global village, we actually agreed that we should achieve health for all by year 2000. And unfortunately, it's year 2012, and we've seen in many different countries that health for all is still not being achieved. This graph will show to you that although for the past century we've added 30 years in general or in average life expectancy globally, there remains a huge gap between the life expectancy of people in the developed world as against to the people in the developing world. Even amongst the populations in the developing world, there is a huge gap between those with low mortality, meaning the countries that have already eradicated infectious diseases like TB, malaria, and for countries in the sub-Saharan Africa, for example, they are still facing the huge burden of infectious disease, hence the red line that separates them from the rest of the developing world. And we know that economic development and life expectancy do have a very high correlation. The richer the country, the better the health outcomes, especially life expectancy. So this is the Preston curve in 2000. And here in this table, you'll see that among countries, Philippines, the general life expectancy is only up to 65. While if you live in Europe, your life expectancy will definitely reach up to 70 plus to 80. But even within cities like Glasgow in Scotland, if you live in the deprived suburb, your life expectancy will only reach up to 54 to 60. While if you live in the affluent portion of the city, you can live up to age 82, 83. Okay. And this gives you a regional perspective, regional context. Even in Southeast Asia, where the Philippines is located, there are huge gaps in terms of life expectancy, with Singapore, Brunei almost having the life expectancy of many rich countries in Europe and in North America, while countries like Myanmar, Cambodia, Laos are still having life expectancy rates or averages comparable to those in Africa. The Philippines is somewhere in the middle of this spectrum. And then in terms of maternal child mortality, Again, Singapore, Brunei, they are enjoying very low mortality rates, maternal death and infant death, while countries like Myanmar, Cambodia are still struggling in terms of these indicators, in terms of achieving the Millennium Development Goals pertaining to child health and maternal health. And then now let's go to the Philippines. This is the situation in terms of maternal health. We know that maternal health is the most important indicator of health of a healthcare system. And in the Philippines, 170 mothers per 100,000 live births are dying. As compared to its neighbors, Thailand, you only have 36 mothers per 100,000 live births dying. And this leads to around 3,000 mothers dying each year, or 11 mothers dying each day. So, and this is very unacceptable in a middle-income country such as ours. I'm sure you've seen the videos or the graphs of Hans Rosling from Karolinska in Sweden. And we tried to make our own gapminder of our country. So the circles, the bubbles represent the different provinces. And as you will see, that the poorer countries or the poorer provinces in the Philippines enjoy low life expectancy compared to the urban centers. Especially the provinces at the bottom, they are the ones that are still experiencing conflict. For many decades, we've been having a conflict between some secessionists in the southernmost part of the country against the government, and we've been having a series of peace talks for the past decades. I think Norway is one of the important mediators in this process for many years, and unfortunately the people who are living in these areas are the ones suffering, especially in terms of health outcomes. And then this interesting, so this is the Philippines. We're an archipelago of 7,107 islands. So if you want to enjoy the beaches in the Philippines, spend your summer in our country. But these islands can also illustrate huge disparities in terms of health outcomes. I want you to focus on maternal mortality, MM. And in the cities, MM, or maternal mortality, can only reach up to 15 mothers per 100,000 live births. But in the poorer provinces, your maternal mortality even reaches up to 150. It's a tenfold difference, which is, again, unacceptable, unfair, cannot be explained by biological reasons. And that's the rationale behind addressing the social determinants of health. There must be lots of determinants in society that are at play, leading to such huge gaps in health outcomes. And in terms of disease profile, just like the developed world, the Philippines and many developing countries are now becoming sicker with non-communicable diseases, cancers, heart disease, stroke, chronic obstructive pulmonary disease, etc. But still we are struggling with infectious diseases like TB and malaria, and interestingly, even HIV/AIDS. The Philippines is one of the 7 countries that have rising HIV rates in the world. It was a recent report from UNAIDS, I think last year. And then this is just a snapshot of the Philippine health situation. 6 out of 10 Filipinos who die, they actually die without seeing a doctor or a nurse. 4 out of 10 families cannot buy the medicine they need. Indeed, in the Philippines, we have one of the highest prices of drugs in Asia compared to its neighbors, Thailand, Malaysia, Indonesia. 70% of health professionals serve only 30% of our population. Majority of them are those who can pay out of pocket. And then our latest national health statistics are 3 years old. So if we are calling for more evidence-based public health policy, then this will be a major problem in terms of health information. health system is chronically underfunded, and 50% of our national health expenditure comes from out of pocket, despite having a national health insurance system which claims to have around 80% of our population being registered as members. So basically that's a snapshot of the Philippine health situation. Now let's go to the social determinants that are at play. Why are we experiencing these glaring inequalities in health? This is an illustration from the report of the World Health Organization Commission on Social Determinants of Health. And every time I talk about social determinants, I look at them through this model, which talks about the downstream determinants, material circumstances, biological factors, lifestyle factors, which we doctors often focus on. But we often forget about the upstream determinants, the global, political, and economic determinants of health, which I will try to touch on in a short while. In terms of socioeconomic inequalities, you will see that the income between the poorest quintile and the richest quintile are very far from each other, around 8 times higher. The income of the richest people are 8 times higher than those of the poorest. And you will see in terms of the share of food in their monthly income, it's the poorer people who pay more for their food rather than the wealthy population. And of course, we know that food is a very important determinant of health. Malnutrition, either obesity, overnutrition, or undernutrition, is now a big problem in the Philippines. Food causing non-communicable diseases are much cheaper than those that can provide better nutrition. And for other families, they don't even have pockets to purchase for their daily food. And then, this is the latest report, 11 million Filipinos, or Pinoys, among the 1 billion people in the world live on less than $1 a day. And we know that you cannot even sustain yourself, have 3 meals a day, bring your children to school if you earn only $1 a day. And we know that the poorer you are, the more prone you are to diseases, to injury. And you will see that the poorest people suffer more in terms of mortality and morbidity, as shown by this illustration. And unfortunately, despite efforts by our government to grow our economy, to bring more foreign investment, this article shows that we've grown 5.5%. In some years, we've even had 7% GDP growth. But even the National Economic Development Authority, which is the prime governing body in terms of economic policy in the Philippines, they claim that the growth has no impact on the poor. So this inclusive growth that we've been calling for has been elusive, especially to the poor people, especially in the recent decades. And you will also see that we are de-industrializing. We know that industrialization in the UK, in Europe, has provided incomes, more stable incomes to people, better jobs, and leading to better health outcomes. But in the Philippines, we're actually de-industrializing. We are growing more our services sector. And in the Philippines, I think we're the #1 now. We just beat India in terms of having the biggest business process outsourcing companies, your call centers, where companies in North America actually utilize our human resources in order to channel transactions, calls, etc. So we are actually #1 in this field, but many people who work in the BPO industry do not have stable incomes. In fact, they are now facing a high risk for sexually transmitted diseases and HIV/AIDS. There were some evidence showing that much of the rise in HIV can be attributed to those working at night in the business processing outsourcing companies. So, aside from our economic problems, we are marred with disasters and the health impact of climate change. We're number 6 in the climate change vulnerability index. We're number 3 in terms of vulnerability to disasters. I'm sure you've heard of the latest floodings in Manila last August, where basically the entire capital became a water world, destroying infrastructure, leading to high rise in leptospirosis and many other infections, people becoming displaced and homeless, etc. So, and this illustrates to you how many typhoons actually visit the Philippines each year. The average is around 20, and could you imagine the impact, the burden that needs to be faced by the government, by the population during typhoon season, which is usually around June to September. And so the government, because we have lots of poor people, we cannot address poverty with our economic growth, so to speak. The government tried to come up with some other measures like the conditional cash transfers, which until now has some conflicting evidence. Some countries will say it worked. In Mexico, the Oportunidades program in Mexico, and then in Brazil, their Bolsa Familia program. But in the Philippines, we're still about to see the effects, and if the cash transfers will actually lead to better health outcomes as well as increase in literacy rates. Cash transfers meaning the government gives cash to the poorest of the poor. In return, the family has to commit to send its children, their children, to school and to visit primary healthcare facilities at regular intervals. But aside from the conflicting evidence, there is also a huge pressure in terms of gathering the evidence, because it's very hard to collect the evidence in an archipelago of 7,107. Philippine health system, these are some of the issues: weak governance, antiquated health information system, the regulation of health goods, drugs is ineffective, fragmentation of healthcare, dysfunctional health workforce, and unjust and unfair healthcare financing. So this is just the structure. We are a highly decentralized and fragmented healthcare system. And these are some of the main issues that we face today. We are one of the 100 countries that are gearing towards universal health coverage. And for the past decade, we've been spending very low or very less for healthcare, around 3% of our GDP, while the recommendation was actually 5%. In Africa, in the Abuja Declaration, it's even 15%. And then more and more of the expenditures are actually being paid for from out-of-pocket expenses or private health insurance. So this is another thing that we need to address in terms of health financing. We are a booming population. We're a population of around 90 million, approaching 100 million. And the resources that we have cannot fully address the needs of our population. But also, this is connected to the very high maternal mortality rates. Mothers do not have access to obstetric care, prenatal care, family planning measures. And so the government for the past 16 years have been debating about the passing of a reproductive health bill. But the Philippines is a predominantly Catholic country. And so this is another issue of governance. The Catholic Church has been exerting lots of pressure to government officials. You lose the Catholic vote during elections. We will excommunicate you from the Catholic Church if you pass the bill. So these are the issues that we face in terms of reproductive health and population management. The sin tax bill is another issue. There's sin tax, meaning taxes for tobacco and alcohol. And there was even evidence that calling the Philippines as the strongest tobacco lobby in Asia, because there are some NGOs that witnessed the lobbyists distributing envelopes to congressmen whenever the sin tax bill is being discussed in Congress. Health workforce, we are manning the National Health Service of the United Kingdom. We are #1 provider of nurses to the United States, #2 provider of doctors to the United States. And, but we have a scarcity of doctors back home, as well as a huge maldistribution. 60% of our countrymen do not see a doctor before dying. And then some of the foreign policy issues that we face, we're basically a recipient of development aid and humanitarian assistance, especially whenever we face disasters. But we are the provider of health workforce to many parts of the world, the Middle East, Europe, and North America. And Southeast Asia, now we're talking about regional health. This is a latest Lancet series about health in Southeast Asia. It's a very interesting case to study. It has so many diverse political and cultural systems, diverse health systems, varying levels of economic development, from the highly industrialized Singapore to a very poor country like Myanmar and Cambodia. And then we're highly vulnerable to so many risks: natural disasters, infectious diseases, and now we are the theater of free trade agreements. We've seen the failure of World Trade Organization, and countries like the US and other developed countries are now looking into bilateral and multilateral agreements which will shape global health and global governance for health in the coming years. We're part of the ASEAN, the Association of Southeast Asian Nations, and we're actually hoping as an ASEAN community to be like the European Union, where there is free flow of goods, services, investment capitals, and skilled labor, meaning our doctors, our nurses, our health professionals will be part of this grand plan to standardize the health sector, to enable free flow of doctors. Unfortunately, we are still yet to study the potential bad effects of such a program. And in fact, there's a latest article, ASEAN doctors are actually not aware that certain agreements are now being set in stone by our foreign ministers and trade ministers, but the doctors who will be part of this transition are not involved in the process. There's another big thing that will happen in the Pacific area, the Trans-Pacific Partnership, which will also impact provision of drugs, access to essential medicines, as well as the flow of health workforce, not just in the Southeast Asian region, but in the entire Pacific, from the Southeast Asia and Australia on the west side to the United States and Latin America and the east side of the Pacific. So basically, these are the countries that will be covered by Trans-Pacific Partnership. The Philippines is still contemplating whether it will be joining the partnership. And this illustration just shows to you that it will have an impact, because it seems that the provisions will be even much stricter than the TRIPS, than the intellectual property policies that are under the auspices of the World Trade Organization. And then we are also part of APEC, the Asia-Pacific Economic Cooperation. And they're also involving themselves in health. Like this one, recently they released the Mexico Principles for Voluntary Codes of Business Ethics for the pharmaceutical industry. So again, it's really the non-health agencies in the Asia-Pacific region that are shaping health policies that will be followed or implemented at the country level. So some take-home lessons. The Philippine health system faces many governance challenges internally, within the health sector, like the Universal Healthcare Agenda, and beyond, like the sin tax. And I'm very happy that, for example, the Department of Health has been working with the Department of Finance in trying to strengthen the case why the sin tax bill should be passed. Because it will be good for the health in terms of more money for health, and it will be good for protecting health, protecting the young, protecting the poor from the ill effects of tobacco smoking. And then global forces also shape national policies. especially those related to or impacting on health. APEC, ASEAN, the Trans-Pacific Partnership, these are new developments in our part of the world, and maybe our Norwegian colleagues would be happy to work with us in trying to investigate and in ensuring that these policies will not affect our populations in terms of health in a negative manner. And then governments must look through a health lens as they negotiate trade agreements and forge foreign relations. So, and I think Oslo, Norway is setting a good example with the latest Oslo Declaration on Global Health and Health Policy that was released last year. We hope that more countries like the Philippines will be adopting this new framework. And then good global governance and national governance will usher action on social determinants to reduce inequalities in health. And I think Waruguru a while ago listed down some of the crucial questions when it comes to GGH, Global Governance for Health, and how we can maximize good global governance to address social determinants in order to lead to better health outcomes, not just for a select few, but for all. So this is the Oslo Declaration that was released last year. And interestingly, 2 countries from the Southeast Asian region are part of the Oslo Declaration, Indonesia and Thailand. So to close my presentation, I just want to invoke 2 amazing people in the field of social medicine, in the field where we are working in right now. Rudolf Virchow, who is the father of social medicine, a German physician, he said that medicine has the obligation to point out problems and to attempt their theoretical solutions. The physicians are the natural attorneys of the poor. Virchow is not saying that we doctors, we young doctors, should be the ones fixing the foreign affairs, fixing the education sector.